Welcome to our video on breast cancer. Let's begin. In this lecture, we'll discuss some general clinical features of breast cancer. The presentation of breast cancer depends on the cancer stage. Usually, a non-tender lump can be palpated, most commonly in the upper outer quadrant of the breast. Lymphadenopathy can also be present, but again, this depends on the stage. In the early stages, lymphadenopathy may be present. Other associated breast skin changes include nipple inversion and skin dimpling or retraction. This is often a sign of infiltration of the breast ligaments. Okay. Let's next discuss the workup. When a patient presents with signs and symptoms of breast cancer, such as a palpable breast mass, the age of the patient determines the initial imaging modality. If the patient is less than 30, an ultrasound of the breast is performed. This is because mammography subjects patients to radiation and is often less accurate in younger, more fibrous breast tissue. When an ultrasound is performed, the lesion can either appear to be cystic or solid. Cystic masses can be simple or complex. A simple breast cyst has a thin lining and is often non-bloody and asymptomatic. A simple breast cyst only requires needle drainage if symptomatic and the patient is concerned. It can also be managed conservatively, depending on the patient's wishes. Complex breast cysts, on the other hand, have thick walls with thick septae. If they have bloody fluid on aspiration or are recurrent, they require a core needle biopsy and/or excision. A solid breast mass detected on ultrasound needs fine needle aspiration, and if non-diagnostic, image-guided core biopsy is then needed. Patients 30 or more with small solid lesions on mammography require core biopsy to confirm the diagnosis. However, if mammography is inconclusive, then ultrasound can be performed on the lesion. Additional tests performed in patients with diagnosed breast cancer include tests for tumor receptors such as estrogen receptor, ER, progesterone receptor, PR, and human epidermal growth factor receptor, HR2/NEU, which will guide targeted treatment. Tumor markers such as CEA can be performed, although they are not diagnostic. To look for metastasis, imaging such as a chest X-ray, CT scan, and brain MRI is performed. Laboratory tests such as increased ALP and increased calcium can be helpful to determine the presence of bone metastasis. A 54-year-old woman is found to have a lesion in her right breast on routine mammography screening. Mammography shows a suspicious 2.5 centimeter lesion in the right breast. Physical exam of the breast reveals a hard, non-tender mass. There is no associated skin or nipple changes of the breast, and no lymphadenopathy is present. What is the best next step in diagnosis of this patient? This 54-year-old patient is presenting with a hard, non-tender mass in her breast that appears suspicious on mammography. The next best step is to perform an ultrasound-guided core needle biopsy to evaluate the mass, confirm the diagnosis, identify the histological type, and find out its receptor profile for further management. In this case, an excisional biopsy would be too invasive. It can be used if the core needle biopsy is inconclusive. Alright, next let's discuss management. Generally, the management of breast cancer depends on the TNM stage. The treatment includes surgery, chemotherapy, radiotherapy, targeted therapy, and hormone treatment or a combination of these. Surgical treatment includes more conservative procedures such as a breast-conserving surgery, where only the cancerous breast tissue is removed, and more invasive procedures such as mastectomy. Mastectomy can be radical, double, and total depending on the stage. Radiation is often given post-surgery to patients at high risk of recurrence, and chemotherapy can be given adjuvant to surgical resection. Hormone therapy of estrogen receptor positive and progesterone receptor positive tumors include tamoxifen, aromatase inhibitors, and raloxifene. Also, targeted therapy against HER2 receptors can be given to patients with HER2 positive tumors. An example of this is trastuzumab. In regards to contraception in women with breast cancer, it's important to know that hormonal contraception is contraindicated in patients with breast cancer. Instead, copper IUD is the contraceptive method of choice. The most important prognostic factor that determines disease outcome is nodal involvement. Patients with axillary lymph node involvement have higher metastatic rate and poor outcomes compared to patients with no lymph node involvement. Good prognostic factors include tumors that are ER positive or PR positive. Poor prognostic factors include a high tumor grade, poorly differentiated, and HER2 receptor tumor overexpression. Finally, let's discuss screening for breast cancer. Patients with no family history of breast cancer are screened starting at age 50. From 50 to 74, women undergo mammography screening every 2 years. Patients at high risk, such as those with a BRCA gene mutations or those with history of chest irradiation, should start screening at 40 years. Patients with family history of cancer, specifically in a first-degree relative, should start screening 10 years before the earliest diagnosis in their family. Alright, now let's solve this question. A 2 centimeter suspicious lesion is detected on routine mammography screening of a 47-year-old woman. Histology reveals a poorly differentiated tumor that shows HER2 receptor overexpression. Sentinel node biopsy reveals tumor infiltration. What factor has the most effect on the prognosis of this patient? So this question presents you with multiple prognostic factors, including a high tumor grade, HER2 receptor overexpression, and sentinel node biopsy revealing tumor infiltration. The question asks about the factor that has the most effect on the prognosis of this patient. The correct answer is nodal involvement. Even though a high tumor grade and HER2 receptor overexpression constitute a poor prognosis for this patient, axillary lymph node status is the most important prognostic factor, as it makes metastatic spread much more likely. This concludes our section